Well, good afternoon, and thanks very much for inviting me to come and talk. I'm very conscious that my world is older people, and the world of older people is very late to the party in terms of this issue of crisis reduction and restraint reduction. It's something that we've never talked about. It's something that we've never done. We've never done it. It's you people that work with children and adult mental health people, you do that sort of thing. We don't in older people. And of course, that's completely wrong and completely untrue. We are coming late to the party. It's starting to be identified as a real issue. It's starting to be recognised that we need to be working out strategies where we can reduce the risks to very, very vulnerable people. When I left, just before I left the Mental Health Trust in 1997, they were, where I'd worked for 20 years, they were starting to introduce, well, they've been introducing for some time, control and restraint, as it was called in the 80s and 90s, and I was told as the senior nurse for an acute admission ward for older people that I was obliged to send all my staff on this control and restraint course, to which I refused, which took me to the director of nursing to find out why I was being so bolshy. And it was because no one was actually considering the fact that that training was wholly inappropriate for frail older people who may have had heart disease, may have had osteoporosis, may have had other arthritis and other issues, that the way that one handles or supports a young, fit, 21-year-old tree surgeon, which is what happened to my son last year when he spent 2 years in a mental health unit and required the services of restraining him, would have been wholly appropriate for him in his condition, but would have been highly dangerous if the same techniques had been used on my dad, who lived for 12 years with dementia and yet had some very resistive behaviours, which meant he had one-to-one specialling for 8 years. The two things are the same but very different, and so we must be sure that we don't just think one size fits all, because it doesn't. But to me, the issue about care and compassion, which I'm going to be talking about for the next 20 minutes or so, actually is the same. It doesn't matter whether you're supporting a young person who's got autism or a person with dementia or someone with an acute mental health problem. How we show care and compassion is exactly the same, because care and compassion is about humanity. It's about how we treat each other as a fellow human being. And perhaps some of the things I'm going to be looking at this afternoon may make some of you feel that I'm dead against staff and I assume everyone does bad things. That's not the case at all. But if we don't actually start looking and holding up the mirror and thinking about some things that might be unthinkable, we cannot be secure in ourselves in knowing that these things don't happen in the units in which we work. So the first and foremost principle is that we have to start being honest with ourselves, that sometimes, in some situations, the aggression or the physical violence that was demonstrated by a patient or a service user may have either been caused or exacerbated by the behaviours and the lack of compassion of the staff, who have been all through the training and got all the competencies and ticked all the boxes. And you can show CQC till it's coming out of your ears about how many people have got this course and this MVQ and that degree and all of that stuff. But have they got compassion? And was it that was missed? So the nature of compassion, what is it? We know it when we experience it. We know when someone's been kind to us and when they haven't. But to be able to define it is very difficult. And there's a lot of research going on where a lot of the academic sort of people are saying you can't really define it, which isn't very helpful. But one Dutch researcher identified it that she feels, Margaret van der Singel, feels that there's seven parts to compassion. And the first part is attentiveness, where it's how we approach the other person as a fellow human being. That we don't approach them as a problem, as an illness, as anything else, but as a fellow human being. How we listen, and whether we stimulate the other person to tell their story in their words. how we confront, which I thought was a very interesting word, but it actually means how we verbalise and acknowledge the suffering and the accompanying emotions that they are experiencing. So we actually say to them about how whatever's happening must be making them feel. So we recognise it. Involvement in recognising the suffering and emotions and the nurse showing that she's concerned. How do we actually show? How do we hold them emotionally at that point? Helping, simply giving someone a hand, the tiny things. Sometimes in a biggest crisis, it might be the smallest thing that makes us feel loved. And I use the word love in an embracing perspective. And presence, simply being there. Not just being in the room, but emotionally, spiritually being there. And understanding, demonstrating that the nurse or care worker understands someone's feelings. That's what brings compassion to any given situation. Can it be optional? Can care and compassion be optional? We hear about it all the time in the NHS. That they're busy, they're overstaffed, they're underpaid. It's David Cameron's fault. Who else do we want to blame? You know, everyone's blamed but the poor nurse. Everyone's held responsible except the poor nurse. That may well be the case. I agree and support what Mervyn was just saying. But it doesn't make it okay. And sometimes we muddle the reasons why something happened, the reason why they went wrong, and say that's okay. We muddle justification and mitigation. It doesn't make it okay. It might explain why it happened. So it's not the nurse or the social worker that gets reprimanded, disciplined or sacked. But actually the real reason why that nurse or social worker was forced to work in that way is then dealt with. It mitigates why something's happened. It never justifies. But what we have to bear in mind is no matter how technically competent we are, no matter how academically clever we are, we can use our head, we can use our heart, our hands, but if we don't use our heart, which is the compassion, the other two are actually a waste of time, in my view. So we know the principles of best practice, we know how to show care and compassion, and we know as human beings it can all go dreadfully wrong sometimes. And with the best will in the world, we can say the wrong thing at the wrong time and upset somebody and cause distress. That's part of being a human being, that's part of being in the caring professions. The widget we make is care. The machine we use to make that widget is a fellow human being. So we're as infallible as the people we're looking after. That's the reality of the world we work in. That's the reality of the world we live in. If we're aware of that, then we can use that to move things forward. So obviously, we're talking about how we de-escalate, how we support someone who's distressed. But what we're also talking about, if we're going to be looking to see if we can make those interventions successful, is the impact that staff can have on the situation and the culture of the care, not only within that unit, but within the organisation and within the team itself. Now, behaviour charts are a wonderful thing, she says. They are, for many of us, a vital piece of equipment. But I do a lot of work as an expert witness, reading through records, and you can build a good picture from records. People say, oh, well, I didn't write it down, but I did it. Well, that's a load of old bunkum, actually. You can pick a picture up. You can build a picture from records. The same as clever doctors can understand all squiggly lines and know what that means your heart's doing. I don't understand the squiggly lines. They do. I build pictures from records. Behaviour charts are one of those records. And they fascinate me sometimes because we all say they've got to be there, but do they always tell you the story that they should? Now, when I was looking and researching this to sort of think, am I being very disingenuous here to the value of behaviour charts, the value of the ABC model, And I just downloaded a couple just to sort of get myself in tune. And one I downloaded, and the antecedent, it said, I was about to put his dentures in his mouth. And the behaviour says, he was sitting up in bed and he punched me in the chest. It was bright and sunny in the bedroom. And I thought, well, that was very interesting. Yeah, very interesting. And then I downloaded one. This is about, obviously, from a school. And it said, it says here, teacher instructs class to move into reading groups. George sighs and puts his head on the desk. So that was the A and that was the B. Now, what's interesting about both these two charts is that they might be fine and they might describe exactly what the antecedent was doing. But in the first one, where we've got, I was about to put the dentures in his mouth, how was that nurse about to put the dentures in the mouth? How was that nurse approaching that gentleman? What exactly was she saying to him? What exactly was she doing? What exactly was her body language? So ABC charts are only as good as the information that's put on it. If they're completed by the person who was the victim, was the nurse, the carer, who was assaulted, attacked, or whatever word is the right word to use, sorry if I'm being politically incorrect at any point with this language, are they actually going to put, well, I went up to him, grabbed hold of his bottom jaw, put my arm round his neck and forced his mouth open, and lo and behold, he hit me. No, they're not. Of course they're not. Because the responsibility will sit with the patient, because they're the ones that are having the behaviour chart. Not the staff that's got the behaviour chart. How many staff have a behaviour chart about how did I behave today when I was supporting those patients? Not many. How did I speak today to that patient? Did I get it right? Not many. So I have a problem, in some senses, with how we use these very important pieces of paper. Because it's not the piece of paper, it's not the concept, it's how it's used, how it's looked at, and how it's interpreted that actually can help to decide whether this person needs to be managed and supported in a different way. So can we be confident that the information about the resistant behaviour, that the information we're given is right? And can we be confident in the organisations that you work in that the training is being carried out? Can we be confident, can you be confident that your staff are showing care and compassion? And can you be confident that when they tell you that Mervyn has been aggressive again, that it was actually Mervyn's problem and not something to do with the way the staff addressed him? Now, I'm going to show you a bit of a film at the next, but I want you to be watching this bit of film. Some of you may have seen it, some bits of it before. It's from the latest Panorama programme. But it's about how these things can absolutely impact and affect someone's well-being and how they're perceived. And afterwards, I want to move on to look at a way that perhaps you in your organisations, in your roles as leaders or practitioners, can start to look at whether care and compassion is actually going on in your care setting. Because you might have all the training in the world, but if you haven't got care and compassion going on, and if it's not celebrated, and if staff don't really understand what it is, then all the rest could easily fall apart. So we will just watch what you're going to be watching is an extract, about 6 minutes extract from the Panorama programme that was on in April. And this is a lady called Joan, who had a stroke 20 years earlier, and she had behaviours that challenged the staff, and the family kept suggesting that perhaps there was other ways that she could be cared for. And as I think you will catch at the beginning of the clip, the home had her on a behaviour chart.
She's got this fierce independence. She thinks she still gets herself up and gets herself washed and gets herself dressed. She cannot do any of those things, though in her mind she thinks she still can.
In the behaviour notes written by staff, Joan is often described as aggressive. She can lash out if frustrated, and Jill has been increasingly worried.
Yeah, no, That's fine, that's fair enough.
But there are definitely ways of dealing with her where she's a pussycat.
Yeah.
Ways of doing it wrong, and all hell breaks loose. I've had the home ring me to say they've been experiencing problems with Mum, being very difficult, quite obstructive with her care, and kicking out and hurting staff. And I said, well, that's very unlike my mum. She can kick off, but it's usually when she's been hurt. And I'm saying you need to look at the reasons why.
It was Lorna who first took Alex in to help with Joan's morning care.
It's aggressive. It's behavior, that behavior record.
Oh, okay.
Yeah, so she's going to hurt you.
Hello, Joan. Good morning, my love.
Joan needs to be washed and dressed.
Just hold her, otherwise she's going to hurt you.
Lorna is physically restraining Joan and asks Alex to help.
Hold her. Hold her.
I don't want that black thing on me. I'm going to dry you.
Well, I'm going to dry it. Thank you. I'm going to dry it.
You need help.
Lorna should be diffusing the situation. Instead, she's winding Joan up.
Do it, shout it.
How?
A bit louder. Try.
Oh, Carol, that's it.
You're just like a tiger.
Oh, you're a bloody idiot.
You, not me. Why are you getting so angry?
Alex doesn't know what to think.
Lorna asked me to hold her arms or her hands to stop her from hurting her. I didn't feel very comfortable doing it. I think because Lorna was taunting her, almost reciprocating the insults that she was throwing at her, it was just escalating things.
We asked consultant nurse Lynne Phair to review Joan's care.
They didn't talk to this lady, they didn't tell her what was going on, they didn't anticipate what her problems were, and all that lady's got is to resist what they're doing to her.
The home told Panorama,
these incidents involved a small number of staff and are not reflective of the high standards of care which we expect and demand from all of our team.
but increasingly staff need the skills to cope with residents who can no longer explain what's wrong.
Good morning, Joan.
Where are we going?
On 28 mornings, our unattended camera in Joan's room shows how care assistants start her day. Joan's paralysed right side is painful, but on too many days she's pulled roughly and she reacts.
I don't want my hair done by you.
Joan's a determined woman who's overcome disability, but she's treated like a child. Treated spitefully.
I'd be embarrassed if you were my mum.
Her knuckles wrapped.
Will you cow?
She's told she smells.
Oh, no, Alex, she stinks.
Well, you stink.
I know I do, it's because I'm working here, it makes you stink.
Joan can be difficult, but this shouldn't be happening.
Hello, nice to meet you.
Thank
How are
you.
you?
After reviewing Joan's care, consultant nurse Lynne Phair is meeting her daughter Jill. She says the home should have been asking questions about the reactions different care workers get.
The organisation have not been looking at the evidence that they've actually got. The evidence would be there, saying there's obviously something going on because of when she expresses her dissatisfaction through aggression, at what times and who are the care staff that were involved.
And there is a clear difference in the way Joan behaves when she's with care assistants who show more understanding.
Joan, can you just wash your hands and face for me? No.
As requested in the family's care plan detailing her needs, they involve her,
Yeah.
Oh, I missed that one though.
chat to her,
You picked it off.
and she's much more relaxed.
Why are you doing this? Why are you doing this?
Get your night dress off, Joan.
No,
We're just
we
doing
never
our
done
job,
it.
darling.
But with Lorna and Anita, the battle with Joan is predictable.
Here's your book, honey.
Lorna throws the bag strap at Joan's head,
Right, have peace and quiet, all right? See you in a minute.
and she's left to struggle on her own. We needed to show Jill what the secret camera had picked up. It's an insight into what can happen when she's not there.
I've had inklings, gut feelings. I'm bitterly disappointed. I spent 2 years with my sister looking for somewhere for Mum to go, and I've let her go there and have that happen to her.
This type of abuse is very insidious. This is hidden. This is like psychological domestic abuse.
Panorama hasn't shown the undercover film to the Old Deanery, but has provided it with details. It says,
"We are shocked and saddened by allegations made by the BBC's Panorama programme of inappropriate behaviour by some members of staff at the Old Deanery care home and apologise unreservedly for those failings."
So, of course, that makes it okay. And it makes it okay that they identified that it was only a few staff. How do they know it was only a few staff? How do they know that the attitude of that senior care assistant, the labelling of that senior care assistant, wasn't something that was actually creeping through the whole organisation? How do they measure care and compassion? Care and compassion can be measured. We've seen it when it didn't happen there. We've seen the harm and the extent of pain and suffering of Joan. But she was labelled as someone who had behaviour problems. She was labelled, she was on a behaviour chart. She was set up to be someone who was difficult. So the chances of them believing the daughter were minimal. The chances of them believing Joan were non-existent, because the organisation had put in place all those things that were supposed to be in place. So it's how you actually identify in your units, in your care settings, whether it's a school or a hospital or a care home, how does care and compassion happen? And they're just very, very quickly, because I'm conscious that time is running out, it can be measured. We did some work in Brighton Hospital of how we can capture care and compassion. How can we identify in public areas if staff are demonstrating that they are showing care and compassion, that they're expressing those tiny things that make the biggest difference? We identified 14 different areas, nothing to do with what was being done, but it was how it was being done. We identified there were positive, passive and poor ways of doing something. Whether you just go up to someone and give them a drink and say, "Here's your drink," whether you go up to someone and say, "Here's your drink," or whether you go up to someone and say, "Hello, would you like your drink?" Exactly the same technical intervention, exactly the same time taken, exactly the same training needed, but actually, hopefully, the last one showed a little bit more care, compassion and kindness than the first two. So we've developed a model whereby anybody can look to see whether care and compassion is going on in the care setting. Because if it's not going on in the public areas, you can bet your bottom dollar it won't be going on in the private areas. So if you monitor care and compassion using this tool for about half an hour, you will identify how much care and compassion is going on. And then you can celebrate that. You can reinforce that with your staff. You can reinforce the behaviours that you expect, the way that you expect people to be greeted, the way that your organisation works. The language that's appropriate to your organisation might not be appropriate to another organisation, another care setting. So you can identify how staff should behave. And then you can also identify, using the tool, where perhaps there's some dispassionate care being demonstrated, or where perhaps there's something, well, I just offered a drink there, wasn't the crime of the century, but actually I need to know that I could do it better. So by looking at how care and compassion is delivered in normal circumstances, in normal situations, you will be able to assess and be able to judge whether or not, when you're looking at those behaviour charts, whether or not you're confident that care and compassion was offered as part of the antecedent. And then whether it's something that you need to be doing to support the patient in their behaviour, or whether it's something that you need to be doing to support the staff in their behaviour. We've developed the tool now, and it is being used. It was very pleased that the government gave it as an example of good practice in the response to the Mid-Staff's inquiry in their document Hard Truths. And it's being used now in mental health. We've got mental health services version, acute hospital, care homes, community services, and it's being used by NHS England to audit, capture care and compassion that is occurring in the high secure hospitals. So I'm very pleased that NHS England are using it in Ashworth, Broadmoor and Rampton. And I was, having used the tool now, having developed the tool and used the tool in many, many places, I have to say that I was really very impressed with when I went to visit Ashworth to see the level of care and compassion that's being delivered. And I have to say, if it can be delivered in such a situation, in such a high secure service as Ashworth Hospital, then I'm blooming sure we should be able to do it in a care home or a general hospital. So if you want more information about the sit and see, it's on, if you just Google sit and see, because it's a very technical description, because that's what you do, you sit and you see. And, but it's very quick, but hopefully it will help you to get underneath whether the culture of care in your environment is one that actually is helping to prevent and reduce problems of violence and aggression, or whether actually the staff on some occasions are contributing to it. Thank you very much.